DLBCL is one of those diseases where when we look at the initial cure rate, we just cannot get over it. We cannot really move the needle more substantially there over the last 20 years, despite thousands of patients being on the clinical trials. But it's really an area of still unmet need and intense research with multiple ongoing clinical trials. So myself and a lot of my colleagues believe that the best chance of curing clear cell lymphoma is really with the upfront therapy. And here where this unmet need, particularly for high-risk patients, lies. And we can cure more people upfront, then we don't have to worry about relapses. CAR T cells in the relapsed refractory disease made a huge difference, but unfortunately, the majority of patients will still relapse after CAR T cells, and they do very poorly. And this is another unmet need. How do we make CAR T cells better in this space? Through either initial bridging to CAR T cells, which are more effective, debulking and make the CAR T cells more effective, but also some of the consolidative strategies after CAR T cells, like with bispecific antibodies. In fact, we now see that those studies are also in progress, trying to build on the CAR T cells and incorporate this in more of a bit longer strategy of treatment to really improve the outcome. And finally, we do have patients with organ dysfunction. We have elderly who are sick, patients who have multiple comorbidities. So how do we incorporate those patients in clinical studies? That's a huge unmet need. We had a recent publication which showed that about a quarter of the patients will not be even eligible for the clinical trials with large cell lymphoma. So how do we really change our studies, and how do we develop studies to accommodate those patients? Because they are at particularly high risk if they cannot actually tolerate standard therapy.